A very good evening to all of you. Myself, Dr. Prateek. Today's topic in ENT is epistaxis. We all know epistaxis means bleeding from nose. That is the bleeding from the nasal cavity, which may be anterior or maybe posterior. So, what is epistaxis? It is bleeding from nose. Types are anterior and comes posterior. The most common site of epistaxis is Little's area. What is this Little's area? See, Little's area is generally, suppose this is my nasal cavity and suppose this is my palate or the floor of the nose, and suppose this is my nasal septum in the midline. So Little's area is the anterior part of the nasal septum. We are talking about septum proper, that is beneath the vestibule. So the septum proper anterior most part where most of the arteries are making a network, like the branches from, firstly from above, the branches from anterior ethmoidal artery, then comes branches from sphenopalatine arteries. This is sphenopalatine artery which is coming out from the sphenopalatine fossa. Then there are branches from superior labial artery. Then there are branches from greater palatine artery. So these all branches will make a network at the anterior part of the septum proper known as Little's area, and this is the most common site of epistaxis, that is bleeding from the nose. What are the causes? Causes are like trauma, one of the most common cause. Trauma by means of road traffic accident, by means of nose picking, by means of chronic rubbing of the nose in cases of rhinitis or sneezing. There are other pathologies like some tumor or cancer of the nose, some sort of foreign body in the nose which will lead to formation of some lith leading to the granulations and bleeding. Then deviated nasal septum and some of the drugs, overuse of the nasal decongestant drugs like overuse of Otrivin, overuse of steroids or cocaine abuse. Okay, so these are some of the factors, local factors, which may result in epistaxis. There are some systemic factors also, like the patients on anticoagulant, like cardiac patient who have recently operated, then they are on the antiplatelet drug, they are on the acetron. Okay, so these patients which are consuming the anticoagulant as well as antiplatelets, they are having the more risk of epistaxis. Then patient with certain coagulopathies, patient with thrombocytopenia like idiopathic thrombocytopenia or some other sort of thrombocytopenia. Then vicarious masturbation or hypertension. Mostly the adult patient, most common cause of epistaxis comes to be hypertension, that is increased blood pressure, and in babies or young adults we can say that trauma is one of the most common cause. Now what are the areas? So Little's area, it is the most common site of the epistaxis where the Kieselbeck plexus is being formed. So generally the bleeding from the nose at the level of Little's area is more common in children. It is at the level of anterior part of the septum. Most common cause is nose picking because babies they have a habit to put their finger inside the nose and just rubbing it. And since Little's area or the Kieselbeck plexus is a network between the arterial branches, so the bleeding source is arterial. Okay, so in children most common site of bleeding is Little's area. If we talk about young adults, so young adults generally one of the common site is retrocolumnar vein. So this is the vein, this is the columella of the nose, and just beneath it there is one vein running. So in young adult One of the commonest site is retrocolumnar vein, which is also present at the anterior part of the septum. There is no very specific cause. It may be because of changes in weather, and it is a venous type of bleed because it is a vein. If we talk about old age, so old age generally hypertension is the most common contributing factor, that is the increased blood pressure, and generally these old age patients will have bleeding at the level of Woodruff's plexus. Where is this Woodruff plexus is located? It is located at the level of lateral wall of the nose, posterior end. That is, if we think, then think about the posterior end of inferior turbinate, or we can say the posterior end of lateral wall of the nose. So this Woodruff plexus is there, and mostly this Woodruff plexus, the branches are from sphenopalatine artery. Because the sphenopalatine artery is emerging from the sphenopalatine foramen, and some branches are going anteriorly and some branches are going posteriorly. So suppose this is, again we are making a diagram of the nose, and suppose this is my sphenoid sinus, and this is my entry to the nasopharynx. So at this area sphenopalatine foramen is there, and this is the posterior part of the nasal lateral wall where the Woodruff's plexus occurs, and in adult or elderly patient this is one of the commonest site for epistaxis, and it is considered more dangerous. Why? Because anterior packing we can easily control by means of pinching, by means of anterior nasal packing, but it is difficult to manage the posterior nasal bleed, and it is also the venous plexus because the sphenopalatine veins are emerging. There is a venous network is there. Then comes the Brown's area. This is the posterior part of septum. Brown's area is present at the posterior most part of the septum, and again there is a venous blood. So you look at this diagram, only the little area bleeding is from the artery, rest all the bleeding are from the venous. Now there are two types of epistaxis we have discussed, anterior and posterior. So let's talk about anterior epistaxis. It is more common but less severe. More common in children, mainly from the little area, that is the anterior-most part of the septum. Usual cause is trauma, and generally the bleeding is mild, can be managed by the local pressure or anterior nasal packing. If we talk about posterior epistaxis, it is less common but more severe. Difficult to manage because if you can pinch only anteriorly, you can't pinch posteriorly. Mainly the area is Woodruff plexus, mostly affecting elderly patient, and the most common reason is hypertension, that is increased bleeding. Bleeding is very severe. Patient may need hospitalization and posterior nasal packing. How to manage epistaxis? Suppose a patient with a nasal bleeding coming in the OPD. The first thing we will ask the patient to sit, not to lie down. Ask the patient to bend little bit forward. Okay? And then ask the patient to pinch the anterior nails tightly, at least for 5 minutes, or we can say 15 minutes, between 5 to 15 minutes. So this is known as Trotter-Hippocrate method. Scientists who suggested this way. So if suppose bleeding stop, well and good. Doesn't stop, what we can do is cauterize either by the bipolar cautery or by means of chemical cautery, that is AgNO3. Cauterize the area which is bleeding, like the little's area. Bleeding stop, well and good. Doesn't stop, what next? We can go for the anterior nasal packing. Anterior nasal packing by means of the roller gauze, or we can use the Marocil. So do the anterior nasal packing both the sides. Never do the anterior nasal packing over one side. Bleeding stop, well and good. Doesn't stop, do the posterior nasal packing, because suppose the bleeding may be from the posterior part, so we have to think of the posterior nasal packing. Even after the packing, bleeding doesn't get controlled, so then we have to think of ligation. The first artery which we ligate is the sphenopalatine artery. Sphenopalatine artery, just try to locate the sphenopalatine artery endoscopically in the OT setup, ligate the artery. So there are certain artery, the order of ligation is like this. Firstly, the sphenopalatine artery, bleeding stop, well and good, doesn't stop, then ligate the maxillary artery. Maxillary artery we can ligate at the level of the pterygopalatine fossa, behind the maxillary sinus. Bleeding stop, good, doesn't stop, look out at the external carotid artery in the neck and ligate that. Bleeding stop, good, doesn't stop. The fourth option which comes in the mind to ligate is the anterior ethmoidal artery, which is the last artery. You can't ligate internal carotid artery. So never think to ligate internal carotid artery. It can be resulting in the death. Okay. So never think of ligation of internal carotid artery. The order of ligation is firstly sphenopalatine, then comes maxillary, then comes external carotid, and lastly anterior ethmoidal artery. Now look at the diagram. This diagram is showing anterior nasal packing. You can see the use of the roller gauze. So we have completely occluded the nasal septum, and by means of the pressure, by means of the ointment, we can stop the bleeding. This is the position where we have to ask the patient to sit down and lean forward. Never ask any patient of epistaxis to lie down and put the neck behind, because what will happen, that will result in the passage of the blood into the nasopharynx, then oropharynx, and going inside your airway, or we can say lungs. So ask the patient to sit, lean forward and pinch the nose tightly. This is the posterior nasal packing, where we can use the Foley's catheter, or we can use the roller gauze tied with the thread and then inserting into the nasopharynx and pulling outwards, so that this baggage which we have tied can stick or block the posterior nares, or we can say posterior choana. You can see here. So we are inserting this and then coming out from the mouth. Taken out from the nose, pulling down. This is the method. Look at the diagram, A, B, C, G.